All right, let's unpack this. Today, we are plunging into the depths of a critical medical emergency, one that really demands not just ophthalmological expertise, but, well, a truly integrated rapid response approach.
Mm-hmm.
We're talking about Central Retinal Artery Occlusion, or CRAO.
Right.
For too long, perhaps, this has been primarily viewed as, a purely local eye issue, something managed just within the confines of ophthalmic practice alone.
Yeah, often siloed.
But this protocol, which is our source material for this deep dive today, it fundamentally reframes that whole perspective. It treats CRAO not just as an isolated eye condition, but explicitly, unequivocally, as an eye stroke.
And that phrase is key.
It is, and this isn't just semantics, right? This perspective shift really underscores the vital systemic implications of a CRAO and highlights the urgent need for management that mirrors exactly how we handle cerebral ischemic events. Time-sensitive, multidisciplinary, and focused on both acute intervention and aggressive secondary prevention.
That analogy of CRAO as an eye stroke is precisely the critical point. It's really the driving force behind the document we're digging into today.
Right.
The Central Retinal Artery Occlusion Management Protocol 2025. It represents a significant step forward, reflecting this crucial shift in how institutions, how clinicians should approach these patients.
Yeah.
It demands, the same level of urgency, the same rapid mobilization of resources, and the same comprehensive systemic workup that we'd apply to a stroke involving the brain. This protocol is our complete roadmap for today's detailed exploration.
And our mission today, essentially, is to take this specific, very comprehensive protocol, which outlines a really systematic pathway, and dissect it, section by section, point by point.
Get into the weeds.
Exactly. We want to understand its detailed approach, not just for maximizing vision recovery in the affected eye, which is, of course, the immediate ophthalmic concern, but just as crucially, to identifying the underlying systemic cause, and then implementing strategies to prevent future, potentially devastating ischemic events for the patient.
Things like another CRAO, yeah.
Or a debilitating cerebral stroke, or even a myocardial infarction. So we're going to journey through this protocol step by step, starting with the absolute imperative of immediate diagnosis in those very first steps, then moving into the time-sensitive, hyperacute reperfusion therapies that might be considered.
Might being the operative word there.
Definitely. Then delving into the urgent workup required to find that underlying cause, discussing the essential components of secondary prevention once a cause is identified, and finally, covering the critical aspects of multidisciplinary collaboration and, the practical referral logistics needed to actually activate this pathway.
And throughout this deep dive, we'll be pulling out the key details, not just stating what the protocol says, but really exploring the why behind each specific step.
The rationale.
The clinical rationale, yeah, and the context that's directly relevant to your practice as a specialist clinician.
Yeah.
We understand you listening possess a deep foundation of knowledge in your respective fields: ophthalmology, neurology, cardiology, internal medicine.
Absolutely.
But this is a focused, granular review and synthesis of this particular detailed protocol. It's designed to highlight its specific requirements, its integrated approach, and its mandate for rapid, coordinated action.
Yeah.
What's fascinating, I think, is how this document mandates weaving together expertise from, seemingly distinct specialties: ophthalmology, neurology, cardiology, internal medicine, into one urgent, cohesive patient pathway. It's really a template for optimal care in a very high-stakes scenario.
Okay, let's unpack this first absolutely critical section of the protocol: immediate assessment and diagnosis. According to this document, where does this entire urgent process begin? What's the actual trigger?
The entire cascade, everything that follows in this protocol, is triggered by one thing: an accurate clinical diagnosis of central retinal artery occlusion.
Okay.
And the source material is exceptionally clear on this point. This diagnosis must be made by an ophthalmologist.
Not just suspected in the ER, has to be confirmed by ophthalmology.
Confirmed by ophthalmology. The presentation that should immediately raise suspicion is the classic one.
Yeah.
Acute, painless, unilateral loss of vision.
Right.
It's usually sudden, often described as a curtain coming down, no warning, affects only one eye, and often leads to severe, profound visual impairment or even complete blindness in that eye.
So the patient describes this sudden dark curtain.
Exactly. But the diagnosis isn't just based on the patient's subjective report, compelling as that is. Critically, according to this protocol, the diagnosis relies on a fundoscopic assessment.
The eye exam itself?
Performed by the ophthalmologist, yes, that visually confirms the occlusion.
Yeah.
Under ophthalmoscopy, you'd be looking for specific signs.
Yeah.
The retina might appear pale,
Uh,
ischemic, because there's no blood flow, especially the posterior pole.
okay.
If the occlusion is of the central retinal artery itself, you'll often see that characteristic cherry red spot at the macula,
The classics.
the classic sign. And that spot appears because the macula, which is thin and gets some oxygenation from the underlying choroid circulation, which isn't affected by the CRAO, it sort of stands out against the surrounding pale, infarcted inner retina.
Right, like an island.
Exactly. Seeing the pale ischemic retina, maybe with a segmentation of blood flow in the arteries, sometimes called box carrying, or even a visible embolus lodged in the artery, that confirms the diagnosis of a central retinal artery or one of its branch occlusions. This clinical picture, confirmed by fundoscopy, is the absolute starting point. It's the signal to initiate the entire urgent downstream cascade detailed in this protocol.
Okay, so the ophthalmologist has made the diagnosis, confirmed it by fundoscopy. The clock is absolutely ticking. What are the very first steps recommended by the protocol while things are being arranged? While more definitive therapies may be transferred to a specialized center that's equipped for these hyperacute interventions, and the full workup are being sorted out. These are listed as immediate first-line measures.
Yes, these are conservative measures, things you can attempt right there, the clinic, the emergency department, the ophthalmologist's office, while the wheels are turning for higher level care.
Okay.
The protocol states they should be attempted, if possible. It lists 2 primary actions that can be performed immediately. The first is ocular massage.
Right. I've heard of this.
Yeah, and while the exact mechanism, how it might help, is still debated, not definitively proven, the underlying idea is that by applying gentle, intermittent pressure to the globe, essentially massaging the eye, you might physically dislodge a potential embolus.
Just try and shake it loose.
Kind of, yeah.
Yeah.
Shake it loose if it's blocking the artery further upstream. The hope is that this physical manipulation, and maybe the fluctuations in intraocular pressure it causes, could encourage the embolus to move downstream into a smaller, less critical branch vessel.
Less damage, hopefully.
Or perhaps allow some reperfusion around it, potentially preserving some central vision if the macula's blood supply gets partially restored via a branch or collateral. It's a simple maneuver, pretty low risk, and can be attempted immediately.
And the second immediate measure listed in the protocol, what's that?
The second is lowering intraocular pressure, or IOP.
Okay.
This can be achieved using standard pharmacological agents, things readily available in most clinical settings. The protocol suggests using topical agents, typically eye drops used for glaucoma, like topical beta blockers, maybe timolol, or alpha agonists like brimonidine.
Standard glaucoma drops.
Exactly. Or alternatively, it suggests administering oral acetazolamide. That's a carbonic anhydrase inhibitor. It reduces aqueous humor production and thus lowers IOP systemically.
Right.
The rationale here is based on a physiological principle. Arterial blood flow to the retina depends on the pressure difference between the mean ophthalmic artery pressure and the intraocular pressure.
The perfusion pressure.
Right. So by reducing the pressure inside the eye, you theoretically increase that perfusion pressure gradient. This might improve blood flow to the ischemic tissue distal to the blockage, even if the main mechanical obstruction is still there.
Makes sense.
Again, these are measures to attempt immediately, bedside, while definitive plans are being made for the patient's transfer and more advanced treatment.
That makes perfect sense. Low risk, quick things you can try right away to potentially improve blood flow or dislodge an embolus, basically buying precious time while the clock is ticking towards those more advanced, time-sensitive interventions. But the protocol immediately pivots from there to another critical, mandatory screening step, particularly for a specific patient group.
This next step is absolutely crucial, and it really underscores the systemic perspective that defines this protocol as an eye stroke pathway.
Right.
It states that in all patients over the age of 50, the protocol mandates immediate screening for giant cell arteritis, or GCA.
Okay, GCA. Why is that so critical here?
Because GCA is a non-embolic cause of CRAO. It's a type of vasculitis, an inflammation of medium and large arteries, including potentially the ophthalmic artery or its branches. Now, while it's not the most common cause of CRAO overall, it is a critical one to identify because if GCA is the underlying cause and it's missed, well, it carries a very high risk of rapidly affecting the fellow eye,
Oh, wow. Leading to bilateral blindness.
leading to potentially devastating permanent bilateral vision loss. You simply cannot afford to miss GCA in this patient population.
And the protocol is exceptionally specific about this GCA workup, right? It's not just a vague suggestion to think about it.
Absolutely not. It is a mandatory step integrated directly into the acute management pathway. You must get an urgent blood draw for two specific inflammatory markers, erythrocyte sedimentation rate, or ESR, and C-reactive protein, or CRP.
Standard inflammatory markers.
Exactly. Widely available lab tests that, when elevated, serve as markers of systemic inflammation.
Now, recall the clinical scenarios where ESR and CRP are typically elevated, suggesting systemic inflammation.
Which can indeed be a hallmark of large vessel vasculitis, like giant cell arteritis. However, and this is where the protocol emphasizes extreme urgency, if GCA is clinically suspected based on the patient's history or other signs, you must begin empiric high-dose systemic corticosteroids immediately.
Immediately, before the labs are back.
Immediately. The protocol specifically states, do not wait for the laboratory results of the ESR and CRP to come back before initiating steroids if your clinical suspicion is high.
Okay.
Now, the source doesn't explicitly list all the signs prompting clinical suspicion, but as specialist clinicians, we know these would include things like new onset headache, especially temporal headache,
Jaw pain when chewing.
jaw claudication, exactly,
Yeah.
scalp tenderness, maybe proximal muscle aching, those polymyalgia rheumatica symptoms, or tenderness over the temporal artery itself. If these symptoms are present in a patient over 50 with a CRAO, the protocol mandates immediate high-dose steroids, typically administered intravenously first, something like methylprednisolone, followed by oral prednisone.
And the goal is?
The goal is emergency treatment aimed squarely at protecting vision in the fellow eye from being affected by the vasculitic process. It's a true ophthalmological emergency within the emergency of the CRAO itself. And this protocol prioritizes preserving potentially unaffected vision above waiting for that laboratory confirmation.
Wow. That immediate empiric steroid step, without waiting for confirmatory lab results, really hammers home the potential severity and the rapid bilateral threat posed by GCA as an underlying cause. It shows this protocol is built to protect the patient's overall visual function, really prioritizing the prevention of bilateral blindness.
It absolutely does. It's a vital diagnostic consideration and a critical protective intervention integrated right into the initial assessment phase. It showcases the proactive risk mitigation approach embedded in this protocol. It's essentially saying, for a patient over 50, if GCA is even remotely possible based on the history, treat it aggressively first to save the other eye, then confirm the diagnosis later.
Okay, so to quickly recap this foundational first section, immediate assessment and diagnosis according to the specific protocol. It all starts with the ophthalmologist's accurate clinical diagnosis. Acute, painless unilateral vision loss confirmed by fundoscopic findings consistent with a central retinal artery or branch occlusion.
Right.
While arranging urgent transfer to a facility equipped for the full protocol, immediate conservative measures like ocular massage and lowering intraocular pressure using topical agents or oral acetazolamide should be attempted if possible.
If possible, yes.
And critically, for all patients over the age of 50, mandatory blood work for erythrocyte sedimentation rate and C-reactive protein for giant cell arteritis is required. But if GCA is clinically suspected based on history and examination, immediate empiric high-dose systemic corticosteroids are mandated, specifically without waiting for those lab results to come back. The primary goal there is protecting the vision in the fellow eye.
Exactly. Protect the fellow eye first.
Now that the immediate diagnosis and initial steps are covered, the protocol moves into the critical, time-sensitive window for intervention in Section 2. This covers the hyperacute reperfusion therapies. And the protocol prefaces this section with some really important caveats right up front, doesn't it?
Yes, and it's essential that the protocol is so explicit and transparent about this. It clearly states that these specific therapies carry significant risk to the patient. And importantly, their benefit for vision recovery in CRAO is still debated within the medical literature.
So not a slam dunk like in some stroke scenarios.
Definitely not. The evidence space for achieving meaningful, lasting visual improvement with these acute reperfusion strategies in CRAO, it's just not as robust or clear-cut as it is for acute cerebral stroke. Therefore, the protocol emphasizes that the decision to proceed with any of these hyperacute therapies must involve a thorough, open, and informed risk-benefit discussion with the patient and their family.
Shared decision-making is key.
Absolutely key. This isn't an automatic, universally applied step. And critically, the protocol states that ideally, this consultation and the complex decision-making process regarding hyperacute interventions should involve a stroke neurologist.
Bringing in the stroke team.
Exactly. This involvement underscores both the potential seriousness and risks associated with these interventions and reinforces the multidisciplinary nature required for managing these eye stroke patients. It explicitly aligns the decision process with how we manage potential reperfusion therapies for cerebral stroke.
Okay. The first hyperacute therapy mentioned in the protocol is intravenous thrombolysis, or IVT. Now, this is a therapy many clinicians, particularly those involved in stroke care pathways, are very familiar with in the context of acute cerebral ischemic stroke. How does this protocol specifically apply IVT to CRAO?
The protocol states that IVT may be considered for select patients. It gives specific criteria that have to be met for a patient to even be considered for this intervention. First, the CRAO must be determined or strongly suspected to be embolic in nature.
Caused by a clot traveling there.
Exactly. Caused by a clot or piece of debris that has traveled to the retinal artery. Second, and perhaps most critically, the patient must present within a very narrow time window, less than 4.5 hours from symptom onset.
4.5 hours, that sounds familiar.
It's absolutely essential, and it's a direct parallel, a deliberate alignment with the established narrow therapeutic window for administering intravenous tissue plasminogen activator, like Alteplase, in acute cerebral ischemic stroke.
Now, recall the typical time window for IV thrombolysis in acute cerebral ischemic stroke, reinforcing this parallel.
Which is indeed 4.5 hours from symptom onset. This direct parallel explicitly reinforces the eye stroke concept and positions CRAO within the same urgent therapeutic landscape as cerebral infarction. Time is brain, or in this case, time is retina.
Right.
Recognizing that retinal tissue is highly sensitive to ischemia and has a limited window for potential salvage is why this narrow time frame is specified for IVT.
And the protocol makes it absolutely crystal clear that before you even think about administering IVT, there's a mandatory imaging step. It's a non-negotiable branching point in the pathway, a prerequisite.
Absolutely non-negotiable. The protocol states that an urgent non-contrast brain CT is mandatory before administering Actalyze, which is the specific drug mentioned for thrombolysis in the protocol.
Okay, so verbally visualizing this, imagine a flowchart at this point, and the very first step is a diamond-shaped decision box asking, has an urgent non-contrast brain CT been performed? If the answer is no, the pathway branches off. You must get the CT before coming back to even consider IV thrombolysis.
Precisely. That CT scan is required before the drug touches the patient's vein. And this scan serves two vital purposes according to the protocol. First, and perhaps most critically before giving a potent clot-busting medication, its primary role here is to rigorously exclude intracerebral hemorrhage.
Can't give a clot buster if there's bleeding?
You absolutely cannot give thrombolysis if there is active bleeding in the brain. It would be catastrophic, worsening a hemorrhagic stroke, or converting an ischemic event into a hemorrhagic one, leading to devastating outcomes.
And the second purpose?
Second, the CT also allows clinicians to assess for a concomitant stroke. It's actually not uncommon for patients with systemic embolic disease to have emboli travel to both the retinal circulation and the cerebral circulation, either simultaneously or sequentially.
So check for a brain stroke happening at the same time.
Exactly. Identifying a co-occurring cerebral stroke is crucial for the patient's overall neurological management and prognosis.
And just like with cerebral stroke protocols for thrombolysis, the protocol for CRAO states that there are patients who cannot safely receive this treatment, right? There are contraindications.
Precisely. The protocol explicitly states that patients with contraindications to thrombolysis must be actively excluded. These contraindications are the standard ones for the use of Alteplase or Actalyze that clinicians are familiar with from stroke medicine. While the source doesn't list all the specific contraindications, they would typically include things like recent major surgery or trauma, any history of intracranial hemorrhage, active internal bleeding, uncontrolled severe hypertension at the time of presentation, certain types of prior stroke, recent head injury, or the use of certain anticoagulant medications. You need to perform a very careful eligibility assessment based on standard criteria before proceeding.
Okay. If the patient meets all the criteria, has no contraindications, and the decision is made in consultation with the patient and ideally a neurologist to proceed, the protocol gives the specific drug and dosing details.
Yes, the drug specified for intravenous thrombolysis in this protocol is Actalyze, which is the trade name for Alteplase. The dose is specifically stated as 0.9 milligrams per kilogram of the patient's body weight.
0.9 milligrams per kilogram.
Correct, with a clear maximum allowable dose of 90 milligrams, regardless of the patient's weight if it calculates higher.
Max 90. Got it.
The administration method is also detailed, exactly matching standard cerebral stroke protocols. A 10% bolus of the total calculated dose is given intravenously relatively rapidly,
10% upfront.
followed immediately by the remaining 90% infused intravenously over 60 minutes, typically using an infusion pump for precise delivery.
And you can't just administer this medication anywhere, right? The protocol specifies the level of care required during and after administration.
No, absolutely not. The protocol is strict and clear about the setting for administration. Treatment must occur in an intensive care unit or ICU setting.
Must be in the ICU.
Must be. This is because the administration of intravenous thrombolysis necessitates strict blood pressure monitoring and control during the infusion and for a period afterwards. Thrombolysis significantly increases the risk of hemorrhagic complications, particularly intracerebral hemorrhage, and meticulous management of blood pressure is absolutely essential to mitigate this potentially catastrophic risk. The ICU setting ensures the necessary constant monitoring by trained staff and the ability to rapidly intervene if complications arise.
Okay, so that's one hyperacute option, intravenous thrombolysis, tied to that critical 4.5-hour window and requiring an ICU. The protocol also mentions another potential hyperacute therapy, hyperbaric oxygen, or HbO2 therapy. What's the time window and potential role for that intervention, according to this protocol?
HbO2 therapy is listed as another consideration for hyperacute management in CRAO, and it has a significantly wider potential time window compared to IVT, which makes it an option potentially when the patient presents too late for thrombolysis.
How much wider?
The protocol states it can be considered for patients presenting within 24 hours of symptom onset.
24 hours. That's considerably longer than the 4.5-hour thrombolysis window.
It is, yeah, giving a much larger window of opportunity. The protocol also mentions that HbO2 may be considered as a salvage therapy if vision has not been restored after other interventions have been attempted.
So maybe not just first line, but potentially as a backup plan.
Potentially, yes.
Right.
It's not exclusively presented as a first-line therapy within that initial 24-hour window. It could potentially be used later as a rescue attempt if other reperfusion strategies haven't been successful, although, the likelihood of significant visual recovery diminishes significantly with time.
And is the protocol specific about the HbO2 treatment parameters, how it's actually done?
Yes, it describes the initial treatment protocol. It specifies administering 100% oxygen
Pure oxygen.
at an elevated pressure of 2.5 ATA, that's absolute technical atmosphere, for a duration of 90 minutes per session.
Okay, high pressure, pure oxygen, 90 minutes.
Exactly. The source adds that subsequent sessions, if needed, would be tailored to the patient's clinical response and visual outcome. The theoretical benefit here is quite intuitive, really.
I hope so.
Well, even with the main arterial blockage reducing or eliminating normal blood flow, if you drastically increase the amount of oxygen dissolved directly in the plasma by cranking up the ambient pressure and the fraction of inspired oxygen, it might be enough to supply sufficient oxygen to the inner layers of the retina just by diffusion from the underlying choroid circulation, which isn't affected by the CRAO.
Ah, so bypassing the blocked artery by supersaturating the surrounding fluid.
Essentially, yes. This could potentially keep the tissue viable for a longer period, despite the lack of normal arterial flow, maybe until some spontaneous reperfusion occurs or collateral circulation develops. It's a strategy to try and overcome the delivery problem by dramatically maximizing the amount of the essential cargo oxygen available in the remaining or peripheral blood supply. Okay, so to recap this second section on hyperacute reperfusion therapies, the protocol clearly prefaces these interventions by noting their significant risk and, frankly, debated benefit, requiring careful patient discussion and ideally neurology consultation.
Right, manage expectations.
Absolutely. Options include IV thrombolysis using actylases at 0.9 milligrams per kilogram, maximum 90 milligrams, administered as a 10% bolus followed by a 90% infusion over 60 minutes. This is for select embolic CRAO patients presenting within that tight 4.5-hour window.
And only after the CT.
Only after a mandatory non-contrast brain CT has been performed to rigorously exclude intracerebral hemorrhage and assess for concomitant stroke, and only in an ICU setting with strict blood pressure monitoring.
Got it.
The protocol also lists hyperbaric oxygen therapy involving 100% oxygen at 2.5 ATA for 90 minutes per session, which can be considered for patients presenting within a wider window of 24 hours from symptom onset, or potentially as salvage therapy if vision hasn't improved with other interventions. Both require careful consideration and shared decision-making.
Right. Moving on from the immediate acute management, Section 3 shifts focus to the crucial detective work, the urgent etiologic workup. The protocol explicitly states that this comprehensive workup should be initiated in parallel with any hyperyouth therapies being considered or administered. Why the emphasis on doing this workup concurrently rather than waiting?
This is perhaps one of the most critical aspects highlighted by the protocol's eye stroke framing. Identifying the underlying cause of the CRAO is vital for two main reasons. First, it helps us understand why this particular event happened to this patient.
Find the source.
But far more importantly, it is absolutely essential for guiding secondary prevention, preventing future, potentially far more devastating ischemic events like another CRAO in the same or fellow eye, a major cerebral stroke leading to permanent disability, or even a myocardial infarction that's a primary long-term goal after the acute phase.
Makes perfect.
Doing this comprehensive workup concurrently with acute treatment means you are not losing precious time. You're not waiting for the outcome of reperfusion attempts or for the patient's vision to potentially improve before you start the search for the source of the problem.
The clock is ticking for prevention, too.
Exactly. The clock isn't just ticking for retinal salvage. It's also ticking for identifying and aggressively modifying systemic risks that could cause future events. This parallel approach ensures that patients leave the hospital not just treated for their acute CRAO, but hopefully with a plan in place to reduce their risk of stroke or heart attack down the line.
Okay. So, according to the protocol, where does this urgent etiologic workup direct us to look first for the potential source of the embolus or the cause of the occlusion?
The first major category the protocol specifies is neurovascular imaging.
Okay. Imaging the blood vessels.
Exactly. The document states that a carotid duplex Doppler ultrasound of the neck vessels should be performed as soon as possible. The primary goal of this test is to exclude a significant carotid stenosis.
Narrowing of the carotid artery.
Right, narrowing particularly on the side that's lateral to the affected eye, meaning the carotid artery on the same side of the neck as the eye that experienced the CRAO.
Why is that the prime suspect?
Well, the logic here is that atherosclerotic plaque buildup in the internal carotid artery can become unstable, and small pieces of plaque or thrombus can break off. These emboli can then travel up the internal carotid artery into the ophthalmic artery,
Which branches off to the eye.
which branches off the internal carotid and supplies the retina, causing a CRAO. Or they can travel further upstream to the cerebral circulation, causing a brain stroke. This is a very, very common source of embolic events.
And the protocol provides specific thresholds for surgical intervention based on the degree of stenosis found by this test. It gives guidance on when to operate.
Yes, the protocol gives clear, actionable guidance based on the findings of the carotid duplex study. It states that an ipsilateral internal carotid artery stenosis of more than 70%, as measured by the duplex ultrasound, is stated as an indication for a carotid endarterectomy.
Surgery to clean out the artery.
It's exactly a surgical procedure to remove the plaque from the carotid artery. And this threshold, more than 70%, is consistent with major guidelines for stroke prevention in symptomatic carotid disease. It reinforces that an eye stroke from this source is treated with the same urgency and indication for intervention as a brain stroke originating from carotid disease.
Now remember the carotid stenosis threshold that, according to this protocol, strongly indicates surgical intervention.
That's more than 70% ipsilateral ICA stenosis. The protocol also adds that surgical consideration should be given to symptomatic stenosis in the intermediate range of 50 to 69%.
Okay, the gray zone.
Kind of. It notes that treatment in this range will be individualized based on factors like the patient's age, overall health, surgical risk profile. Again, aligning generally with standard stroke prevention guidelines for this level of stenosis when it's considered symptomatic.
The protocol also mentions CT imaging again in this section on etiologic workup, building on what we discussed as a mandatory step before thrombolysis in Section 2. What's its role here in the workup context?
Yes, it reiterates the role of urgent brain imaging here. It states that an urgent non-contrast brain CT is mandatory before administration of Actualize, as we discussed, specifically for the purpose within the workup context of excluding intracerebral hemorrhage, which remains paramount before any consideration of antiplatelet or anticoagulant therapy later on, and also to assess for concomitant stroke. Identifying a simultaneous cerebral stroke is part of understanding the full picture of the patient's systemic embolic or thrombotic burden and guides overall neurological management.
Even if they didn't get thrombolysis.
Yes, even if the patient presented outside the thrombolysis window or had contraindications, Obtaining brain imaging is still standard in any comprehensive stroke workup. You want to look for associated pathology, signs of previous strokes, or underlying structural issues. The protocol also notes that while an MRA, magnetic resonance angiography, of the head and neck vessels typically takes longer to acquire and interpret compared to a CT, it can be considered as an alternative if CT is not available, or if more detailed vascular imaging is needed. MRA can provide excellent detailed visualization of the cerebrovascular anatomy, identifying stenosis, dissections, or other abnormalities.
Okay, so we've thoroughly investigated the major arteries in the neck and head as potential sources using neurovascular imaging. What's the next major category of potential emboli sources the protocol directs us to investigate in this urgent workup? Where do we look next?
Once carotid sources have been excluded or not deemed the primary cause, the protocol directs the workup toward a cardiac evaluation.
Look at the heart.
Exactly. This is the primary place to look for the source of an embolus if it didn't originate in the carotid arteries. The heart is a significant generator of emboli, particularly in older patients or those with underlying heart conditions like atrial fibrillation or valvular disease.
And what are the preferred imaging tests for the cardiac evaluation according to this protocol? What's the best way to look?
The protocol states that cardiac emboli should ideally be investigated with a transesophageal echocardiogram, or TOE.
TOE? Why is that preferred?
It's specified as the preferred method because it offers superior visualization compared to the standard transthoracic echocardiography for many potential embolic sources within the heart.
Okay, verbally visualizing this again. Imagine the difference in perspective here. A transthoracic echocardiogram, or TTE, is like looking at the heart from the outside through the chest wall using ultrasound probes placed on the skin. It gives a good overall view, but can be limited by things like ribs, lungs, or body habitus, making it harder to see certain areas clearly.
Right, sometimes the windows aren't great.
Whereas a transesophageal echocardiogram, TOE, involves inserting a specialized ultrasound probe into the esophagus, the swallowing tube, which sits directly behind the heart. This position allows for much closer proximity and clearer imaging of key structures that are common sources of emboli, like the left atrium and especially its appendage, a common site for thrombus formation and atrial fibrillation. The interatrial septum, where you might find a patent foramen oval, or PFO, the mitral valve, and the aortic arch. This closer view makes TOE much more sensitive for detecting small thrombi, vegetations from endocarditis, or structural abnormalities like a PFO that could allow clots from the venous system to cross into the arterial circulation.
Exactly right. However, the protocol does acknowledge that a TOE isn't always immediately available in every center or at all hours. It can be more resource intensive.
True.
So it states that a transthoracic echocardiogram, or TTE, is a reasonable alternative if a TOE is not available. While it's less sensitive for certain findings, like small left atrial thrombi, a TTE can still identify significant structural heart issues, assess global cardiac function like left ventricular ejection fraction, low EF, can predispose to thrombus formation, or detect significant valvular heart disease, which can also be a source of emboli, so it's still valuable.
Okay. Beyond structural heart issues or thrombi you can actually see on echo, cardiac arrhythmias, especially atrial fibrillation, are also a major source of emboli. How does the protocol address screening for that as part of the workup? How do you catch a fib?
It includes mandatory monitoring for arrhythmias as a critical component of the cardiac workup. The protocol specifically recommends either continuous ECG monitoring.
Keeping them on a monitor in the hospital.
Exactly. The patient is on a heart monitor throughout their hospital stay, or obtaining a 24 to 48-hour Holter monitor.
The take-home monitor.
Right. The explicit purpose stated for this monitoring is to screen for paroxysmal atrial fibrillation. This type of AFib is intermittent. It comes and goes. It might not be captured on a single resting ECG performed when the patient first arrives. Yet even paroxysmal AFib is a very significant high-risk factor for cardioembolic stroke, including CRAO, because blood can pool and clot in the left atrium and appendage during those episodes of irregular rhythm. Identifying AFib is crucial because it requires specific, often lifelong anticoagulant therapy for effective secondary prevention. So this extended monitoring is essential detective work to catch potentially silent AFib.
Okay. So as part of this urgent workup, we've checked the carotids and the heart using imaging and monitoring. What about blood work beyond the initial GCA screen mentioned back in Section 1? What further lab tests are mandated by this protocol?
The protocol lists further blood work as an essential part of the etiologic workup, comprising a comprehensive panel of tests. These are aimed at identifying underlying systemic risk factors or sometimes less common causes of clotting.
Okay, what's included?
It specifically mentions ordering fasting lipids and HbA1c. These are standard tests for assessing cardiovascular risk factors. Fasting lipids identify dyslipidemia, abnormal cholesterol and triglyceride levels, and HbA1c gives you an average blood sugar level over the past few months, screening for or assessing control of diabetes.
Standard risk factors.
Right. Managing these risk factors aggressively is crucial for secondary prevention, regardless of the ultimate cause of the CRAO. But identifying them here reinforces the need for this aggressive long-term management. The protocol also adds that a hypercoagulability screen should be performed.
A clotting workup.
Exactly. It notes that this is particularly indicated in young patients, those typically under maybe 50 or 55, where traditional atherosclerotic or cardioembolic causes like carotid plaque or AFib are less likely culprits, or in patients with no other obvious cause found after the carotid and cardiac workup described above has been completed and is negative.
So if the usual suspects aren't found, dig deeper.
Dig deeper, exactly. This hypercoagulability screen targets less common etiologies that make a patient's blood more likely to clot inappropriately.
And what types of conditions is that hypercoagulability screen typically looking for in this context? What are those less common causes?
Well, a hypercoagulability screen typically looks for inherited or acquired conditions that increase the risk of thrombosis. While the protocol doesn't list them exhaustively, for you listening, this would imply testing for things like factor V Leiden mutation,
Wow.
prothrombin gene mutation, maybe deficiencies of natural anticoagulant proteins like protein C, protein S, or antithrombin, possibly elevated levels of homocysteine, or acquired conditions like antiphospholipid syndrome.
Right.
These are less common causes of stroke or arterial clots, but they're important to identify, particularly in younger patients or when the more common causes have been ruled out, as they may require very specific management strategies, often involving long-term anticoagulation.
Okay, let's do a thorough recap for Section 3, the urgent etiologic workup. And remember, the protocol mandates this is done in parallel with any hyperacute therapies.
Right, don't wait.
We cover neurovascular imaging. This includes a mandatory carotid duplex Doppler looking for significant stenosis with surgical consideration for ipsilateral internal carotid artery stenosis of more than 70%, or individualized consideration for symptomatic 50 to 69%. Mandatory non-contrast brain CT is required before thrombolysis, specifically to exclude intracerebral hemorrhage and check for concomitant cerebral stroke. And MRA is noted as a reasonable alternative if CT isn't available.
Okay.
Then we proceed with a comprehensive cardiac evaluation, ideally with a transesophageal echocardiogram, TOE, for superior visualization of embolic sources, or a transthoracic echocardiogram, TTE, if TOE is not available.
Preferred versus alternative.
This cardiac workup also includes essential screening for paroxysmal atrial fibrillation with mandatory continuous ECG monitoring or a 24 to 48-hour Holter monitor.
Don't miss the AFib.
And finally, comprehensive further blood work includes assessment of cardiovascular risk factors with fasting lipids and HbA1c, and a hypercoagulability screen, specifically indicated in young patients or if no other cause is found after the initial workup, to look for those less common prothrombotic conditions.
And you mentioned a mnemonic earlier, a way to potentially remember these key areas.
Yes, the mnemonic CAFE. How did that go again?
Right, CAFE. Think of it as a quick checklist for the workup components. C for carotid CT, checking the carotids with duplex and the brain with CT. A for arrhythmias, specifically screening for paroxysmal AFib with Holter or continuous monitoring. F for further blood work, including those fasting lipids, HbA1c, and the hypercoagulability screen. E for echo, performing the cardiac echocardiogram, preferably TOE or TTE if TOE is unavailable.
CAFE, carotid CT, arrhythmias, further blood work, echo. That's actually pretty helpful.
Hopefully useful, yeah.
Okay, now moving on to Section 4, which is absolutely vital for long-term patient outcomes, secondary prevention and medical management. The acute event has been managed, the urgent workup is underway or completed to find the cause. Who is this section aimed at according to the protocol, and what is its core directive? What's the main message here?
This section applies to all patients with the confirmed embolic or atherosclerotic CRAO. So once the workup identifies that the CRAO was caused by an embolus, maybe from the carotid or the heart, or by local atherosclerosis, the directive is exceptionally clear and strong. They should be started on aggressive secondary prevention.
Aggressive, not just consider.
Aggressive. This underscores a fundamental principle in stroke management, which this protocol explicitly applies to eye strokes. Successfully managing the acute event, whether or not vision was restored, is only the first step. Preventing a recurrence of any ischemic event, another eye stroke, a potentially disabling brain stroke, or a heart attack, is paramount for the patient's long-term morbidity and mortality. This section provides the framework for reducing that future risk.
And what are the main pillars of this aggressive secondary prevention strategy as laid out in the protocol? What does aggressive mean in practice here?
The protocol specifies three main interconnected areas that form the foundation of this aggressive approach. First, antiplatelet therapy.
Okay, blood thinners.
Well, antiplatelets specifically. The protocol states to initiate single or dual antiplatelet therapy as per stroke guidelines. This explicitly acknowledges and reinforces that eye stroke concept. CRAO, when embolic or atherosclerotic, is treated analogously to a cerebral ischemic stroke in terms of long-term prevention strategies. Standard antiplatelet regimens used for secondary prevention of cerebral stroke should be applied here.
So using agents like aspirin or maybe clopidogrel or sometimes a combination depending on the specific cause found and the current standard stroke guidelines this protocol aligns with.
Precisely. The choice between single or dual therapy and the duration of dual therapy, if used, would typically be guided by the specifics of the diagnosed cause. Maybe small vessel disease, large vessel atherosclerosis, certain cardioembolic sources, and the relevant current stroke prevention guidelines. But the mandate to initiate antiplatelet therapy is clear.
Okay, pillar 1, antiplatelets. What's the next pillar?
The next pillar focuses on lipid management. Statin therapy.
Statin.
Yes. The protocol mandates initiating high-intensity statin therapy. It gives atorvastatin 80 milligrams per day as a specific example dose, clearly indicating the required intensity level.
High intensity, like atorvastatin 80 or rosuvastatin 40.
Exactly those levels. And crucially, and this is a really key point, it explicitly states this should be done regardless of baseline cholesterol levels.
Regardless, even if their cholesterol is normal.
Regardless. This is a fundamental concept in contemporary cardiovascular and stroke prevention guidelines that is applied here to CRAO. The benefit of high-intensity statins in preventing future vascular events in patients with established atherosclerotic disease or those at very high risk extends beyond simply lowering LDL cholesterol numbers.
Ah, the pleiotropic effects.
Exactly. These medications also possess important pleiotropic effects, which include stabilizing atherosclerotic plaques, reducing inflammation within arterial walls, improving endothelial function, and having some antithrombotic properties.
Now, recall the class of patients for whom high-intensity statins are recommended for secondary prevention, regardless of their initial lipid levels.
Which includes patients with established atherosclerotic cardiovascular disease. CRAO, when due to atherosclerosis, clearly falls under this category. That justifies the mandate for aggressive statin therapy regardless of the patient's initial cholesterol numbers, because the benefits extend beyond simple lipid lowering to include these important plaque-stabilizing and anti-inflammatory effects that reduce the risk of future events.
Okay, so pillar 2, high-intensity statin for pretty much everyone with embolic or atherosclerotic, CRAO. And the third pillar addresses the broader picture of cardiovascular health, right? Beyond specific medication.
Exactly. Risk factor control. The protocol emphasizes ensuring optimal management of all modifiable cardiovascular and cerebrovascular risk factors.
The usual suspects.
The usual but crucial suspects. This includes rigorous control of blood pressure, meticulous management of diabetes, comprehensive support for smoking cessation, and addressing other vascular risk factors such as diet, exercise, weight management, and potentially obstructive sleep apnea if that's relevant.
The foundations.
Absolutely the foundation of all cardiovascular and cerebrovascular prevention. Aggressively managing these factors, targeting guideline-recommended blood pressure goals, achieving and maintaining good glycemic control, good HbA1c, in patients with diabetes to prevent both microvascular and macrovascular complications, providing robust support, counseling, and maybe pharmacological interventions for smoking cessation. Smoking is a major driver of atherosclerosis and thrombosis.
Huge factor.
And encouraging healthy lifestyle habits, diet, exercise, weight, it significantly reduces the overall burden of atherosclerosis, improves vascular health, and lowers the risk of future thromboembolic events originating from various sources throughout the body. It's the comprehensive, holistic approach necessary for long-term protection after a sentinel event like a CRAO. Okay, so to quickly recap this fourth section on secondary prevention and medical management, which applies to all patients with a confirmed embolic or atherosclerotic CRAO. It mandates aggressive long-term management built on three essential pillars. First, initiating single or dual antiplatelet therapy as per standard stroke guidelines.
Right.
Second, initiating high-intensity statin therapy, giving atorvastatin 80 milligrams as the example dose, and crucially doing so regardless of the patient's baseline cholesterol levels due to the broader vascular benefit.
Got it.
And third, ensuring optimal control of major modifiable vascular risk factors, including blood pressure, diabetes, smoking cessation, and other relevant lifestyle factors. It's a package deal.
Absolutely. Moving to Section 5. This section explicitly highlights the collaborative nature required for managing these complex patients effectively. Multidisciplinary team collaboration and follow-up. The protocol strongly emphasizes, as we've touched on, that this isn't a condition managed in isolation by a single specialty. It really requires a coordinated approach across different medical disciplines.
It does, and this is a key strength of the protocol, recognizing that optimal outcomes require integrating expertise. The protocol specifically mentions a designated individual, Dr. Gregory Weir in this case, who will be responsible for arranging the required special investigations, all the neurovascular imaging, cardiac tests, blood work we discussed in the etiologic workup section, and for consulting with appropriate specialists.
So a point person to quarterback the process.
Exactly. It indicates a central point person or service coordinating the logistical complexities of getting all these tests and expert opinions organized rapidly and efficiently.
And who are the specific specialists listed as being key to consult with as part of this multidisciplinary approach? Who needs to be involved?
The protocol names neurology, cardiology, and internal medicine as the key specialists to be consulted in the management pathway.
Makes sense based on the workup.
It directly reflects the likely underlying systemic causes of CRAO that were investigated in the etiologic workup. A neurologist is crucial for assessing the patient for any concomitant cerebral stroke, managing neurological aspects, and contributing to the neurological etiology workup.
Right.
A cardiologist is essential for identifying and managing potential cardiac sources of emboli findings, AFib, structural heart disease, valvular issues, and assisting with comprehensive cardiovascular risk factor optimization.
Okay.
And an internal medicine specialist plays a vital role in managing complex medical comorbidities, optimizing general medical health, and contributing to the overall systemic risk factor control and long-term prevention plan. Their combined expertise ensures all potential systemic factors contributing to the CRAO are addressed.
Communication back to the referring physician is also mentioned as a specific point in this section, isn't it? Closing that loop.
Yes, absolutely vital. The protocol states that telephonic feedback will be provided promptly to the referring ophthalmologist. This is a critical step for ensuring seamless continuity of care.
Yeah, they need to know what happened.
Exactly. The initial diagnosing physician, the ophthalmologist who first saw the patient and initiated the pathway, needs to be kept fully informed of the patient's progress through the protocol. That includes the findings of the comprehensive workup, any acute, hyperacute management provided, the diagnosis of the underlying cause, and the plan for secondary prevention upon discharge. This rapid communication maintains a strong link between the acute specialist care provided at the implementing hospital and the ophthalmologist who will likely continue to follow the patient long-term for visual assessment and ongoing eye care.
And what about structured follow-up after the patient is discharged from the hospital following this pathway? Is that specified?
Yes, it is. The protocol specifies that a follow-up assessment with the referring ophthalmologist will be arranged upon the patient's discharge. This closes the loop on the acute event and the initial systemic workup and prevention planning.
Back to their eye doctor.
Back to their eye doctor, exactly.
Yeah.
The patient returns to their original ophthalmologist for a post-event assessment of their visual outcomes following the CRAO, assessing the extent of any visual recovery or residual deficit, and for ongoing ophthalmological care related to the consequences of the retinal ischemia or any related eye conditions. It ensures the patient doesn't get lost to follow up after the initial comprehensive systemic management is initiated by the multidisciplinary team.
Okay. So for Section 5, the multidisciplinary team approach is fundamental. It explicitly involves consultations with neurology, cardiology, and internal medicine, coordinated by a specific contact person like Dr. Gregory Weir, who manages the complex investigations.
Right.
Prompt telephonic feedback is given directly to the referring ophthalmologist to maintain continuity of care.
Keeps everyone in the loop.
And a specific follow-up assessment with the referring ophthalmologist is mandated and arranged upon patient discharge to assess visual outcomes and provide ongoing ophthalmic care.
Those are all bases.
The final section, number 6, covers the essential practicalities required to make this protocol work on the ground. It focuses on referral logistics and data management. This section seems very specific to the local implementation details outlined in the source document. How does it help the referring doc?
It absolutely is very practical. This section provides the actionable details that an ophthalmologist diagnosing a CRAO would need to know to immediately get the patient into the system outlined by this protocol and ensure they receive this urgent, comprehensive care. It clearly gives the specific referral contact, Dr. Gregory Weir, the same individual mentioned in Section 5 for coordinating investigations,
The point person again.
establishing him as the gateway to this protocol. Crucially, it provides his direct contact information, his room's phone number, 01-233-58651, and his dedicated cell phone number, 082-498-2652.
Direct numbers, no switchboard delays.
Exactly. This contact information is explicitly provided for the purpose of arranging the immediate admission of the patient to Life Eugene Moraes Hospital, identifying this specific institution as the site where this urgent protocol is implemented.
So for a referring ophthalmologist, this isn't just a theoretical guideline, it's a specific actionable pathway. Here's the number, here's the person, here's the place. Go.
Precisely. It provides the necessary practical information, the who to call and where to send the patient, to bypass potential administrative delays and ensure rapid transfer and initiation of all the urgent protocol steps we've discussed. From the immediate GCA screen and potential hyperacute therapies to the comprehensive etiologic workup and planning for secondary prevention. It transforms a protocol from a theoretical document into an immediately actionable plan for referring physicians facing a CRAO emergency.
The protocol also mentions how this pathway will be applied consistently and monitored over time, doesn't it?
Yes, it states clearly that the suggested protocol will be applied to all eligible patients. This signifies a commitment to a systematic, consistent approach to care for all patients presenting with CRAO who meet the eligibility criteria defined by the protocol, ensuring equitable and standardized management.
And data collection.
Yes, importantly, it details the data management aspect. All patients managed under this protocol will be entered into a prospective database.
Okay, what is the primary purpose stated for collecting data in this prospective database? Why do that?
The database is explicitly for monitoring and quality improvement.
Ah, QI.
Exactly. Collecting structured data on patients managed according to this specific, detailed protocol allows the team implementing it to rigorously evaluate outcomes. Things like rates of visual recovery, identification of underlying etiologies, rates of subsequent cerebral stroke or other vascular events, adherence to the protocol steps.
See what's working, what's not.
Precisely. This data is invaluable for identifying areas where the pathway is succeeding, where challenges exist, and where improvements can be made to optimize patient care and outcomes. It also mentions that anonymized data will be supplied to the Pretoria Eye Institute on a regular basis,
Sharing the data.
suggesting a contribution to a larger registry or research effort, which can contribute to the broader understanding, evidence base, and improves management of CRAO beyond the single implementing institution. It helps everyone learn. Okay, so to wrap up this final 6th section, it details the essential practical steps for implementing the protocol. Contacting Dr. Gregory Weir via the provided room's phone number 01-233-58651 or cell phone number 082-498-2652 for immediate admission to Life Eugene Moraes Hospital.
Direct and specific.
It notes the protocol will be consistently applied to all eligible patients and that all patients will be entered into a prospective database for rigorous monitoring and quality improvement.
Learning from experience.
And anonymized data will be shared regularly with the Pretoria Eye Institute, demonstrating a commitment to evaluation and contribution to knowledge. It's about making the system better over time.
Okay, wow. We have now systematically gone through the entire Central Retinal Artery Occlusion Management Protocol 2025, section by section, dissecting its detailed, systematic approach. Let's try and bring it all together now in a comprehensive mega recap, synthesizing the entire urgent pathway described in this document from start to finish.
Right. Let's consolidate. This protocol makes a clear, impactful statement by establishing CRAO as an urgent stroke equivalent, demanding a stroke-like response.
The core message.
It begins with the ophthalmologist's accurate clinical diagnosis, based on confirming acute, painless unilateral vision loss with characteristic fundoscopic findings.
Diagnosis is step one.
Immediate conservative measures like ocular massage and lowering intraocular pressure are attempted while arranging urgent transfer to the implementing hospital.
Do what you can immediately.
A mandatory and critical step for patients over the age of 50 is the Giant Cell Arteritis screen with ESR and CRP, requiring immediate empiric high-dose systemic corticosteroids if GCA is clinically suspected based on symptoms.
Don't wait for labs if suspicious.
Specifically, without waiting for those laboratory results to confirm, as the priority is protecting the fellow eye.
Then, with the patient transferred, the protocol details the consideration of time-sensitive hyperacute reperfusion therapies, acknowledging their significant risk and debated benefit, necessitating careful patient discussion and ideally neurology input.
Exactly. The risky stuff. This includes intravenous thrombolysis using Actalyze at 0.9 milligrams per kilogram, maximum 90 milligrams, 10% bolus, 90% infusion over 60 minutes.
The specifics matter.
Considered for select embolic CRAO patients presenting within 4.5 hours from symptom onset, but only after a mandatory non-contrast brain CT to exclude hemorrhage and check for stroke, and only in an ICU setting with strict blood pressure monitoring.
Lots of only ifs.
Very specific criteria. It also includes hyperbaric oxygen therapy, 100% oxygen at 2.5 ATA for 90 minutes, considered for patients within 24 hours or as salvage therapy.
Wider window for HBO.
And crucially, initiated in parallel with those acute therapies, a comprehensive workup for the underlying cause is performed without delay.
The parallel workup. Find the cause.
Yes, the urgent etiologic workup is initiated concurrently because it is crucial for secondary prevention. This involves neurovascular imaging, carotid duplex, looking for stenosis greater than 70% needing endarterectomy, symptomatic 50 to 69% considered.
Check the pipes.
Brain imaging too, CT mandatory before thrombolysis, MRA, an alternative to exclude hemorrhage and check for stroke. It includes a thorough cardiac evaluation, preferably with TOE or TTE if needed, and screening for paroxysmal AFib with continuous or 24 to 48 hour Holter monitoring.
Check the pump and the rhythm.
And further blood work fasting lipids, HbA1c for risk factors, and a hypercoagulability screen in young or unexplained cases, using that CAFE mnemonic, carotid CT, arrhythmias, further blood work, echo.
Right. Once that comprehensive workup identifies the cause, aggressive secondary prevention is immediately initiated for all patients with confirmed embolic or atherosclerotic CRAO.
Which, as we discussed, is the fundamental step for long-term outcomes, preventing future events. This involves initiating single or dual antiplatelet therapy per standard stroke guidelines.
Antiplatelets.
Initiating high-intensity statin therapy, like atorvastatin 80 milligrams, regardless of baseline cholesterol levels.
High-intensity statins.
And meticulous risk factor control, optimal management of blood pressure, diabetes, smoking cessation, and other relevant vascular risk factors.
Manage everything else. And as the protocol strongly emphasizes, none of this complex urgent pathway happens in a vacuum. It requires seamless collaboration and structured follow-up across disciplines. Teamwork is essential.
Absolutely. The protocol explicitly outlines the necessary multidisciplinary team collaboration involving neurology, cardiology, and internal medicine consults, coordinated by a specific contact, Dr. Gregory Weir in this example.
Coordinated care.
Prompt telephonic feedback goes directly to the referring ophthalmologist to keep them informed, and a specific follow-up assessment with the referring ophthalmologist is arranged upon discharge.
Closing the loop, finally, the protocol specifies the essential referral logistics needed to activate this pathway, providing Dr. Gregory Weir's specific contact numbers for immediate admission to Life Eugene Moraes Hospital.
Makes it easy to refer.
It notes this protocol will be consistently applied to all eligible patients, and all patients entered into a prospective database for monitoring and quality improvement, with anonymized data shared with the Pretoria Eye Institute.
System improvement built in.
Wow. That was a truly deep dive into the intricacies of this specific Central Retinal Artery Occlusion management protocol. It's crystal clear how seriously it treats this condition and how many distinct pieces of the puzzle, from immediate ophthalmic diagnosis, urgent GCA screening, potential hyperacute interventions, detailed systemic etiologic workup done in parallel, aggressive long-term secondary prevention, and mandatory multidisciplinary collaboration have to come together rapidly, systematically, and seamlessly to provide optimal care for these critical patients. It's a complex dance.
It really is. And what's truly fascinating here is the rigorous step-by-step yet integrated approach it outlines. It doesn't just list possibilities. It provides a clear, actionable pathway.
Yeah.
It demands rapid coordination across specialties and explicitly applies principles typically reserved for cerebral stroke management. It serves as a powerful, practical reminder that the eye is indeed a crucial window to the systemic circulation, and that eye strokes are just as critical to address rapidly for both visual recovery and for preventing future systemic events as brain strokes. It really elevates the management of CRAO to its rightful place as a true medical emergency.
So, based on this protocol, what does this all mean for you, the specialist clinician listening, navigating these urgent cases in your own practice or institution? What's the takeaway?
Well, I think this protocol raises an important and perhaps challenging question for implementation everywhere. How well integrated are ophthalmic emergencies like central retinal artery occlusion into the broader stroke protocols, the rapid response systems, and the established multidisciplinary teams within your own hospital or region?
Is the eye connected to the rest of the stroke system?
Exactly. This protocol provides a template, considering how to adapt or implement such a streamlined pathway, ensuring rapid access to the necessary specialized imaging and consultations, and consistently initiating comprehensive secondary prevention. That's crucial for optimizing patient outcomes, both visually in the affected eye and, perhaps even more importantly, systemically in preventing future disabling or fatal events.
Yeah.
It highlights the immense value and necessity of having a clear, actionable, and well-communicated protocol like this one in place to guide urgent, complex care. Without a plan, things can fall through the cracks.
A lot to think about there indeed, particularly in bridging that gap between ophthalmology and broader stroke care pathways and emergency response systems. We hope this deep dive into the Central Retinal Artery Occlusion Management Protocol 2025 has given you valuable insights and actionable takeaways for managing these critical, time-sensitive patients and perhaps evaluating the protocols and pathways in your own practice environment.